Welcome to the May meeting of the Injury and Disability Insurance Data Interest Group. I'm Michael Di Donato, and I will be host/presenting this afternoon. I'm just admitting people. Apologies, 1 moment. Okay. Before we get started, in the spirit of reconciliation, we acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. So welcome to the Injury and Disability Insurance Data Interest Group. It's quite a long name. We haven't met in a while. So as a refresher, this is a regular opportunity or a semi-regular opportunity for people with an interest in personal injury and disability insurance data to share knowledge, exchange ideas and learn from one another. So in the past, we've had presentations from researchers from our university, but also some folks from up in Queensland. And we're always happy to have people present. So if you have an idea to present in the future, or you would like to present something, please do let me know. We would love to hear from you. The group also aims to connect and support members with common areas of interest and specialisation, promote professionalism and understand research and using data within the Australian personal injury and disability insurance sector. So where are we from today? Now, I made a poll. Let me just launch the poll. So what kind of organisations is everyone from? If we answer that, we'll come back to that later and see where everybody's coming from. So the Healthy Working Lives Research Group, that's our team at the School of Public Health and Preventive Medicine at Monash University. We're part of, like I said, the school. Our research program encompasses three main themes of prevention, recovery and systems. We lead local and national and international research projects to provide expert advice and consultancy services and deliver bespoke education and training with the mission that good work is good for health and good health is good for work. One of the Kim Burton phrases from quite a while ago. So before we go on, I would be remiss if I didn't do some shameless advertising. Our postgraduate program is expanding in our team, and we currently offer 3 units, 3 micro-credential units, which are worth 6 credit points. So we have 2 more running this year. Personal Injury Strategic Claims Management runs from July to September, and Personal Injury Scheme Evaluation we're running for the first time starting in September. Those are run in partnership with the Personal Injury Education Foundation and can be used towards a postgraduate certificate in personal injury management or even a master's as well. But if you'd like to know more, please do get in touch. So on today's agenda, the topic which I'm sure you've seen when you signed up on Eventbrite, the utility of workers' compensation, healthcare and medicines administrative data, what we can measure, can't measure and might measure. So first up, you'll be hearing from me about what we can currently measure, or what we think we can currently measure. And then you'll be hearing from my colleague, PhD student Jonas Tefera, who will be talking about capture, coding and reporting of healthcare and medicines information in Australia's workers' compensation systems. This is based on a recent survey of workers' comp sector employees that Jonas ran, and then we'll have some time for discussion at the end. So without further ado, we'll get underway. What I should note today is as well that you would have seen on the way into Zoom, this session is recorded, just to note. So what can we currently measure with healthcare administrative data? Just to start off with, I should acknowledge that the data used in the studies that you'll see today was supplied by WorkSafe Victoria, WorkCover Queensland, Return to Work South Australia, and WorkCover Western Australia. And the views expressed by myself and my co-authors are those of our own, not necessarily the views of those organisations. But we would like to thank these organisations for providing data and helpful input in our project so far. I'd also like to thank Dr. Yili Fang and Ms. Diane Beck. A long list of co-authors here on the information you're about to see, and a long list of organisations, some of which I've already mentioned as well. I should also note that this work was variously funded by the Australian Research Council, Safe Work Australia, and for my time, the Australia and New Zealand Low Back Pain Research Network. So, healthcare services in workers' compensation. Well, it's a large bit of expenditure for workers' comp. It's something that doesn't normally get thought about because it's not quite as big as the income support component. But if we take a look at this data from Safe Work Australia from 2020 to 2021, we can see that services to claimants, which is healthcare, rehabilitation, medicines, anything that workers' compensation is paying for to rehabilitate workers, constituted about just under $2.5 billion, which is about 22% of the entire workers' compensation expenditure. If I go back there, you can see that direct to claimant, which is wage replacement and other income support reimbursement, was close to $6 billion. But still a critical component at $2.5 billion per annum worth of healthcare. And so what do we mean when we say administrative data, or administrative data in the context of healthcare services, particularly in workers' compensation insurers and regulators? Well, workers' comp insurers and regulators collect and generate massive volumes of data as part of their normal day-to-day business operations. And this is administrative data. So what this might typically look like, I've just made up some services data here, but you'll have an individual identifier. In most cases in the research we deal with, that's de-identified, but a claim number, for example, you'll have a service item code, service item description, a service date, so when that service occurred, and perhaps a provider identifier. And Jonas will talk about this more later, but service items are variously coded and described. For those in the audience who are familiar with it, you'll notice that that is an MBS code, as is the code beneath it. So it's MBS code from imaging and so forth, because those are quite medical services, but here's a randomly generated code for physiotherapy. You might see some codes for medicines, some other codes for imaging, stuff like that. So that's what we mean when we say administrative data. It's effectively large databases of receipts for services that have occurred. Now, how can we use this administrative data? Well, there's a couple of good publicly available examples of using administrative data and reporting that have come out. This one is a good example. This is the Open Data Dashboard by Return to Work South Australia, and provides kind of aggregate statistics on categories of expenditure. So they've just aggregated service items like physiotherapy and so forth, and we can see trends in expenditure for different categories of services. There's a similar system in New South Wales. This is CIRA's Open Data Dashboard, and these are fantastic. So these provide a great initial view, I suppose, of open data. There's plenty of other sources for this kind of thing outside of workers' compensation, but today we're talking about workers' comp. We can use it in more sophisticated ways as well. So these are just some examples of some studies that myself and others have been able to do over the last few years with healthcare administrative data. We've been able to identify that about half of claims for low back pain have diagnostic imaging. We've used trajectory modelling, which we'll come back to later, to identify patterns in opioid prescribing. We've looked at measures of continuity of care, so that's seeing the same clinician, looked at differences between jurisdictions, looked at medical assessments, mental health services. We can look at anything. So administrative data is pretty cool. We can look at a lot of interesting stuff. But we can use it in more precise examples, which is what we're going to talk about today. So just a quick sidebar to low back pain. I'm sure people have heard of low back pain and or experienced it, if the numbers are anything to go by. It's the leading cause of disability worldwide, linked to 60 million years lived with disability per annum. And it's the leading cause of non-fatal disease burden in Australia. You can see this report here from the Australian Institute for Health and Welfare. In workers' compensation schemes, it is also very prevalent. There's, in 2010 through 2015, we identified about 56,000 claims for low back pain with greater than 2 weeks time loss. And they have about a median, an average of 9 weeks time loss, which is roughly the same as a claim for a limb fracture. So quite a disability burden associated with low back pain. And so we're talking about low back pain because the sample of the study I'm going to display today is of a sample of workers with low back pain. So this is a sample from the multi-jurisdiction workers' compensation database, which is a database we brought together of healthcare administrative data, and you can read more about that in our open access paper, and we've got some other presentations on that too. But the sample we'll be talking about today is workers with accepted workers' compensation claims for low back pain between 2011 and 2015 financial years. They've been off work for at least 2 weeks. We've got covariates such as the worker's sex, age group, occupation, socioeconomic status, and their remoteness. And we're going to be looking at physical therapy attendances, I should say physical therapy rather, in the first 2 years since their claim was accepted. And we'll be looking at single or group sessions, and we've removed some duplicates, but we can talk about that more in a moment. So this is kind of some of the first stuff we can do with administrative healthcare data. So how many workers attend physical therapy? A nice straightforward question. Well, in our sample of 28,000 workers with low back pain, 82% attended some sort of physical therapy in the first 2 years of their claim. So that's 23,619 workers. But as you can see, the vast majority attended only physiotherapist. So this has just come out in a new paper that came out online 3 days ago now, I believe. But we can see that the vast majority in workers' compensation see physio only, whereas only 2.2% saw chiro only, even less saw osteo only, and there was a mix of people who saw more than one profession. And even when we look at the total volume of services, so over 500,000 services were included in this sample, in this study, and 93.9% of those were for physiotherapy. And then 90% of those services were for individual services rather than group sessions. Now, it's interesting when we look at this kind of thing because we know in the private health insurance sector that physiotherapy and chiropractic are much closer matched. So that's another form of healthcare administrative data that we can use. But this is, like I said, this is the kind of insights we can start to get. And we can get even a bit more sophisticated with administrative data when we look at how often somebody attends physical therapy. So I'll just orient you to this graph. This is that same sample of people from before. We've got our 21,000 people who only went to the physio, 528 who only went to a chiro, 296 who only went to an osteo, and then 1,700 people who went to multiple therapists. What we have here is the median number of times that they attended each of those therapists. And so we can see here that 21,000 people attended a median of a physiotherapist rather, a median of 13 times, whereas, for example, in osteo, 296 people attended the osteo only 10 times. And then the people who attended multiple therapists, we found attended a median of 31 times. And when we run our statistical analysis, we identified that those who attended chiro and osteo did so significantly fewer times than those who attended only physiotherapy. But those who attended multiple types of therapists attended significantly more times. So again, we can get even more detailed with administrative data. But what are the patterns of attendance? So we can take a subsample of that group, 22,768 workers who saw just the physiotherapist. So this is the physiotherapist only, because as we know from the previous slide, chiro and osteo was relatively infrequent. So let's look at just the people who saw physiotherapists, and we can model patterns of their care. So I'll just orient you to this table here. So what we can see here is each column here is an interval of days from claim acceptance to the time the service occurred. So for example, this 0 to 30 here would be between 0 days since claim acceptance, so from the day of claim acceptance to the first month. And then for each worker, we've counted the number of times that they've gone to the physiotherapist. And we've done this every 30 days, and then it goes up to 2 years. And with this kind of administrative data and statistics, it doesn't look like much. We're talking about a table here that would be, 30 columns wide by 22,768 rows long. But what we can do is start to identify some patterns. So if you look at this here, these workers, they seem to have a similar kind of peak attendance. They go to the physio twice between 30 and 60 days. They continue to see the physiotherapist a couple of times in the next interval. And this is where we can use some pretty sophisticated statistical techniques to cluster these individuals, to understand patterns about them. So what you're seeing here is the output of a trajectory model, a group-based trajectory model, where we took all those 22,000 people and clustered them by the number of times they saw a physiotherapist every 30 days for the first 2 years of their claim. And you can see we've got 4 groups. As I mentioned, half of them fall into this kind of little green line here. We have 11,000 people who have a short-term, low volume pattern of care. But you do get this red line here of people, about 7% of our sample who, even at 6 months into their claim, are attending the physiotherapist 6 times every 30 days, so once every 5 days. So you can start to see some outliers and some patterns evolve in our data. And what do those look like in terms of the total service volume? So similar statistics to what we were using before. If you remember before, on the whole sample, people who went to the physio went a median of 13 times. But when we're able to use those more advanced trajectory modeling techniques, we can see that 50% of people are actually going 7 times. So they've got a lower service utilization. They're going fewer times to the physiotherapist. But our other groups here are going more and more until we have this group of 1,600 people who, over a 2-year period, are going to the physiotherapist 100 times. Now, this includes single and group sessions. So somebody could go to a couple of group sessions a week, for example. But it does allow us to identify some really important patterns in health service utilisation. And if we remember back to earlier on, we're talking about $2.5 billion per annum, roughly, in healthcare costs. So we can start to identify these important patterns with this data. It really underlines the utility of healthcare administrative data. So what does this mean in the context of physiotherapy? Well, we can, like I said, we can draw a number of meanings from it. There's no clinical guidance about the number of times to see a physiotherapist, but 39 sessions or 100 sessions seems like quite a lot. We know from some other reports that physiotherapy is relatively cost effective, but if you think in terms of being an insurer or a workers' compensation regulator, one initial appointment, 99 standard consultations, we're up to almost $8,000 in physio, excluding on costs, transport, and whatever other services that individuals had. So it can all add up in terms of costs, and that's where these modelling techniques are useful. And we can also look at some important differences between states and territories. So we do a lot of comparative research in our team between workers' compensation jurisdictions, which are independent in each Australian state and territory, as I'm sure many people know, looking at our poll numbers from our attendees. But what we've done here is take those trajectory groups and we've compared everyone to the short, low volume group, that's that green line, that 50% of people, and the state of Queensland. And then we're going to compare each jurisdiction to that and what's the likelihood of being in a higher group. So if we take WA here, for example, we can see that WA, there's no difference between WA and Queensland in terms of which worker might be in the next trajectory group up, the short-term high-volume group, we've called it. But it's more likely that a Western Australian worker could be in the long-term low-volume group or the long-term high-volume group compared to Queensland. We could look at South Australia as well. That difference appears to be amplified slightly. And then we can look at even Victoria, where Victorian workers we find they have a lower prevalence, lower access to physiotherapy, but we can see, interestingly, they have a much higher likelihood of being a long-term, high-volume group. And so we can take our, statistical techniques and then, observe clear policy differences between jurisdictions, and particularly where that impacts healthcare. So administrative data is awesome. At least I think so. We can perform detailed population scale analyses using sophisticated techniques. We can, using de-identified ethical research approaches, we can provide important insights to stakeholders, all stakeholders involved, be that healthcare, workers' compensation regulators, insurers. I presented some of this data last year at the physiotherapy conference, just straight to physiotherapists, which was an interesting conversation. But there are some downsides and potential for improvement, which Jonas will talk about. But at least in our physiotherapy example here, there's a lot of unknowns. So what did the physios actually do? We're not sure. Again, this is administrative data that's generated as part of day-to-day operations, and clinical information about, did the physiotherapist use a biopsychosocial approach for people with low back pain, for example, was probably included in case notes, but probably didn't make it into structured administrative data. How disabled were these workers? We know they had low back pain, but we don't know what level of pain they had. What was their employer like? How many years of experience did the physiotherapist have? Were they junior or senior? Did the workers have access to other income support systems? We're talking just here about workers' compensation, but we know from life and from some of the research we've done that things are more complicated than that. People can access income support in Australia from a number of other options. For example, Centrelink, Social Security, but even life insurance and other options too. So there's a number of other factors that we just miss. So those are some of the important downsides to think of. And on that note, I will hand over to Jonas Tefera. Now, Jonas is a pharmacist by training, and he is currently a PhD candidate in our team at the School of Public Health and Preventive Medicine. Jonas's project explores prescription medicines use and its outcome in injured Australian workers. So, Jonas, if you'd like to share your screen, the floor is yours.
Hello, everyone. Could you see my screen? Okay, thank you. Thank you for introduction, Michael. My talk could be on capture, coding, and reporting of healthcare and medicine information in Australian workers' compensation system. I would like to begin by acknowledging the traditional owners of the land on which we meet today. I would also like to pay my respects to elders past and present. Here is a list of co-authors for the work I'm going to present. And I would like to extend our gratitude to the study participants across various Australian workers' compensation jurisdictions and the leadership of each jurisdiction. And these particular individuals from Institute for Safety, Compensation and Recovery Research, Samantha Barker, and Corey Grandi from Safe Work Australia for giving feedback on the contents of our questionnaire. To give you a brief background information on the healthcare more broadly in the conventional way and healthcare in workers' compensation system. The conventional healthcare system in Australia is funded and regulated by Commonwealth government, as most of you know. Healthcare in workers' compensation system is specifically funded and regulated by a specific territory, the state, or the national Commonwealth government authorities. It depends on the jurisdiction. Our team has been previously working on different data sets from different jurisdictions, and during this time, we identified the healthcare and medicine use across these jurisdictions is substantial variation, and similarly, the data collection and coding approaches across these schemes is quite different. Such variations have limited, due to such variation, we have nationally limited insight regarding the overall healthcare use and medicine utilization across these different workers' compensation jurisdiction. We have limited insight only, most of the predicted insights are on the cost-wise, so we don't have extensive insights regarding the medicine use, healthcare use by this jurisdiction. But this detailed information is essential determining whether the Australian workers' compensation schemes are supporting evidence-based healthcare. Particularly, there are growing reports coming from international workers' compensation jurisdictions, and in our prior research, harms associated with service use, overuse, or misuse. So such information is essential to these schemes to evaluate their service effectiveness. Having this background, we specifically aim to answer the following questions: how healthcare is and medicine data is captured, coded, and reported? What healthcare and medicine data are captured and coded? And what coding schemas are used in various Australian workers' compensation jurisdictions? So we conducted a cross-sectional survey in major workers' compensation jurisdictions of Australia. We specifically set eligibility criteria. The participants should be employed currently by a workers' comp scheme as regulator or insurer, providing claim management service. And the participants should have direct knowledge of claims and service data capture or coding. And we also asked to raise their knowledge of how healthcare and medicine data is collected, coded, and reported on a 5-point Likert scale. And those with self-ratings of very limited or limited knowledge have been excluded from our analysis. So the characters of the respondent, we finally included 25 participants representing regulators, 40%, and 60% representing insurers across the 6 states, 2 territories, and 1 national Commonwealth scheme. The participants have 4.4 plus or minus 4 years of experience in their current role, and totally they have a mean of 14.6 plus 10.5 years of experience in the workers' compensation industry more broadly. For our specific question, the approaches to capture and healthcare and medicine information, we asked how this information is collected. We have asked sources of information for both medicines and healthcare. We found that the main source of healthcare and medicine information is payment records, invoices, or receipts, seconded by healthcare provider records or such as medical certificate, file notice, worker self-report. The proportion of use is quite different across jurisdictions. And we also found pharmacist reports are a source of medicine information. We asked them if they collated this information into structured database. We found 88% collect this information to database for the healthcare data, and 72% collect this information for the medicines data. We asked how they enter this data into the database. Mainly it is entered by the case manager, more than half of the participants, followed by they have employed a dedicated data entry personnel. And some jurisdictions have automated system that extract information from the payment applications. We also asked how often they enter this information to the database. Relatively large proportion of them said they have constant stream of data entry continuously, followed with a different proportion, daily, monthly, and some says they don't know the frequency, how they enter into the database. We have asked also if there is a protocol for reviewing the quality of data entry. Interestingly, 60% of the participants, they have the data entry protocol for the healthcare, while only 8% has the protocol for the data entry for medicines data. Large proportion doesn't have quality control mechanism for medicines data. We further asked what information about healthcare is captured. There's 3 types of information is mainly collected for healthcare data, date of service, the cost of service, type of service across all the jurisdictions, while other information are collected in some jurisdiction, while some other jurisdiction doesn't collect this information out. We also asked what coding standards they are using to collect this healthcare data. Large number of participants are saying they have their own unique scheme organization generated codes defined by their respective scheme regulator or insurer to code this data. 40% of them said they will use MEBS codes to code this healthcare data. We have also asked about similar questions: what information about medicine is captured? Large proportion of respondents said they only record cost. We have asked plenty of information relevant to medicine utilization studies, but the response proportion is quite different. Extensively collected information is cost or the amount paid for the specific scripts. Nearly half, more than half of the information, respondents record generic name of the medicine, but large number of information is rarely collected. The coding standard for these medicines are asked as well. Equally, PBS, pharmaceutical benefit scheme item codes and scheme defined codes are used in 28% of the participants, while large number of the respondents, they don't know the coding standards for the medicines data. We further asked the data reporting approaches of this medicine and healthcare data. External stakeholders have been asked. The three major external stakeholders to report this data are other compensation scheme stakeholders, government department or agency, and general public. No medicine data is shared to general public, while compensation stakeholders are the main stakeholders reported this either healthcare or medicines data. We have asked the formats of their presentation. Most of them reported in ad hoc basis or as bespoke report within decreasing order. They may report in as periodic statistical summary or actuarial reports or annual reports. Specific to the internal reporting, the main audiences for the internal reporting are the senior executives. The format of their reporting is mainly a PowerPoint presentation in decreasing order. The outcome measures, how they measure these jurisdictions measure outcome for healthcare data. Cost is the main outcome measure. We have asked other outcome measures for healthcare data: nature of service, frequency, prevalence, incidence rate of this service use, time to first service. We have asked also a large variety of healthcare outcome measure, but the main reported measure of outcome is cost, followed by the nature or type of service for the healthcare data. Similar questions are asked about how they measure the medicine's outcome data. Cost is the main outcome measure similarly, followed by the frequency of prescriptions per claim or the pattern of medicines over time is their outcome measure, but this is relatively in lower proportion as compared with the cost. We further asked about training and support either they received. 48% of the respondents said they have received any in-person training before, or 40% said they have informal support, support by coworker. 36% of them responded they have received written training material regarding this medicine data management, but a quarter of them never received any support or training regarding the medicine and healthcare management within their jurisdiction. More than half of expressed interest in receiving further training and support. So the recommended training or supports are, they require clear guidance on industry standards. They suggested improved systems that are less error prone and can hold large amount of data in user-friendly format. And they suggested mapping of unique scheme codes to more national consistent codes. They also require training on point of creation validation coding, and they suggest integration of automation and artificial intelligence solutions in their day-to-day operation. Also, they suggested specific privacy trainings. So, summary of main findings. Every jurisdiction collects some form of healthcare and medicine information, but the depths of information and methodologies, data source, coding schemes, and reporting approaches vary across this jurisdiction. Large gaps and blind spots exist mainly with medicines data. Some jurisdictions appear to collect and report medicine information, while a minority of these jurisdictions does so in greater detail. However, there is a growing interest and shift in approaches to medicine data within some of the jurisdictions. For instance, there is a transition from a single pharmaceutical pay code to multiple medicine codes, which allows to collect large number of information regarding medicines. So there is a growing interest to collect a large number of information about the medicines. So implication into policy and practice. Australia's workers' compensation system spent significant fund to injured workers' healthcare and medicines besides to the income support. So it appears that some do not always routinely employ standard data coding procedures. The current approach doesn't allow us to have a full understanding of the healthcare and medicine utilization across these jurisdictions. So it limits the ability to assess whether the healthcare and medicines provided to these injured workers are value-based, and it is important to address such limitations. So more harmonized, improved national data system is imperative to address existing shortcomings. A consistent approach would provide clearer insights into the healthcare utilization of these injured workers. So further supporting from policy and practice improvement. This includes what healthcare interventions are effective, which are not. An example of standardized system could be seen with TOCS, a type of occurrence classification system, which has served as a number of valuable research projects throughout Australia. And it served as a national monitoring effort, including estimates of national burden of occupational injuries by Safe Work Australia. So harmonized and improved national data system is more imperative to address existing variation. Future research and recommendation. This is the first attempt to highlight how the healthcare and medicines data managed from these various workers' compensation jurisdictions. So this study is intentionally limited on selected professionals from these schemes to understand the overall scheme variation without delving to individual scheme differences. So future research may benefit from further exploration of these cross-jurisdictional and organizational differences. This might potentially offer more specific insights and tailored recommendations to these different entities involved through the process of this workers' compensation. So I'd like to thank you for your attention. If you want to read the full article, it is published in Journal of Occupational and Environmental Medicine. Thank you.
Fantastic. Thanks, Jonas. I'll just Just sharing your screen there, and I'll open up the floor to any questions or commentary from the audience. Anybody wanted to jump in there? While people are shy and think of questions, I might ask one first. So it was pleasing to see, I suppose, that a lot of these people responding to our surveys were asking, we're rather measuring some of the outcomes that we already measure in, I suppose, in academia. But was there anything that surprised you, Jonas, in the responses from the survey? Anything that wasn't being measured that you thought should be a priority?
Yeah, the main thing I understand from the respondents is they are very keen to improve data system. I didn't particularly find the specific outcome measures they suggested, but they are very keen to have more improved data system to accommodate large number of information regarding the medicines and healthcare. So yeah, that is quite interesting for me.
I think one of the things that you found in that paper was that there's not really national standards for a lot of healthcare like there is for TUCS, for injury coding, or for a lot of the ABS standards for socioeconomic area, for example. And that's part of the reason why I chose to talk about physiotherapy today, because a lot of, we saw in your survey results that the MBS is used quite a lot, the MBS coding. But for those familiar with the MBS, you'd know that really there's only 2 physiotherapy items in the MBS. It's not really funded by the MBS. And so to bring together that data that you saw from those 4 jurisdictions took a fairly substantial amount of work from the team here to go through individual codes and decipher, is PT 001 in one state the equivalent of PY 0001 in another. A lot of reading definitions of services, but I agree with the respondents to the survey. A national standard for healthcare coding would be excellent. If there is not any other, oh, hang on. All right, Matt Stevens. A couple of questions. Pattern of attendance, to look at predictors of patterns at all. All right, medicine. We have looked at, so Matt's question there was, have we been able to look at predictors of physiotherapy service patterns? Thanks for the question, Matt. To answer that, we have looked at worker predictors, I suppose. So in the paper that's published in Pain at the moment, you will see that we've looked at age, sex, remoteness, socioeconomic status. Off the top of my head, people in more remote regions were in the kind of shorter term groups of patterns of care. We haven't looked at other services or medicines as predictors of being those patterns, but that would certainly be a good bit of research for the future. We've used that same technique to model medicines dispensing, but we could combine the two. There's a technique, group-based multi-trajectory modeling that we may be able to apply in that area. And then the second part of your question, do you have any method of communicating your recommendation through to insurers, regulators, different states, nationally consistent coding? That's an excellent question. We always like to have seminars like these where we can disseminate these papers and findings and so forth. And we try to also regularly, we're regularly in contact with a lot of regulators and insurers and folks in the industry. So we like to share these results, but yeah, hopefully that's our method at the moment. A question from Kim here. Were there any insights into the shared and differentiated characteristics between the 4 clusters? Yes, well, there were some differences and then there were some not significant differences between those patterns. So for example, when we did the study and we clustered opioid dispensing, we found that people in lower socioeconomic areas tended to be in the longer term opioid dispensing patterns, whereas in the physiotherapy, there wasn't really a great deal of difference. And there was, the only really significant differences between the two, the major significant one was jurisdiction. That comes down to a couple of reasons that may be to do with funding. I know certain jurisdictions fund at different rates for different, like pre-approved amounts of time. So one theory we had was, in Queensland, they will pre-approve a much smaller tranche of services of times you can go to the physiotherapist than other jurisdictions. And we used Queensland as a reference group, which is why there was larger differences there. We used Queensland as a reference group because it was the largest group, I should know, in statistical models. But I just see your cameras come on there, Kim. Does that kind of answer your question?
Yeah, kind of, because it's, I mean, when we look at, and so also sports and exercise physio by background before moving into consulting, and worked clinically for many years, but didn't do workers' comp because it didn't pay enough for the last kind of 10 years of my clinical life. There's a couple of things in here. The kind of clinical pathway and trajectory somebody ends up on is often very much dependent upon the gatekeeper, i.e. the GP. So I suppose part of this as well is not only are there shared characteristics of the individual person on claim, but also of the gatekeeper provider involved in their care. Any insights into that?
Yeah, I mean, there were a lot of changes as well over that period, and probably subtle changes, but they probably had a bit to do with it. So, for example, Queensland, for a standard physiotherapy consultation, pays quite a lot more. And the physiotherapist in Victoria can also sign continuing certificates of capacity for workers. So they may be acting in a administrative role in addition to their clinical role. I mean, I think any clinician working in workers' comp acts in at least some administrative role, but there may be more of that in some jurisdictions as opposed to others. In 2014, Victoria also introduced the Early Intervention Physiotherapy Framework, which increased the price of physiotherapy depending on how long it had been since your injury. There were different prices there. And we did see in the data that, obviously that became more popular. So that may be contributing to the reason too. And one other thing we did do, which is that model that I demonstrated there comparing jurisdictions, was adjusted for total wage replacement duration. In the model, not adjusting that, the differences were quite a bit larger, but we generally find that Victoria does tend to have longer claims. We've seen that in previous research. And so, we can't say that more physiotherapy led to a longer claim or vice versa, but, if you're off work for longer, there is a greater opportunity to access more services.
Exactly.
Would be the way to describe it.
Very lovely description of correlation versus causation.
Yes.
And I think there's another piece in here in understanding all of those things we know that add duration to a claim are not captured. Well, sorry, they're created, they're captured, but they're not stored within the databases particularly well. So things around the psychosocial factors, but also comorbidities. We know that people with greater comorbidities, it has a big influence on their recovery trajectories, things like that. Any thoughts into how that could evolve?
Well, excellent question. I mean, we know that, for example, a physiotherapist would have to provide functional outcome measures in their justification to continuing services, but we don't tend to see that in the structured administrative data. So, some of those bits of data, like scores and rankings and so forth from like Oswestry, would be fairly easy to add as a variable to administrative data, and could have some explanatory power when added to models. So I think there's real opportunity to add those kind of variables. Some of them obviously are quite challenging, and some of them are already collected. I mean, in the National Return to Work survey, and my colleagues here that use it more often may be able to remind me, the Kessler 6 was added to that, which provides kind of a score that could be integrated into administrative data. So there's potential to add some important measures in there that could really add to our explanatory power in these models.
Yeah, great. Thank you.
Thanks, Kim. We're coming up to time here. I'm not seeing any more questions in the chat. I think I'm sharing the poll of where we are from everybody's from today. I don't know if people can see that. But interestingly, a real mix. Nobody from CTP regulators, so that's all right. Stella's just raised her hand. Stella.
Hi, Marco. Thanks for the lovely presentation. I was just trying to type in my question. So question for you, Michael. In case I've missed it, did you manage to look at multiple comorbidities with or multiple injuries with the low back pain?
No, so the sample that we defined was just using type of occurrence classification system codes to code for low back pain. And so that's the initial condition that somebody has claimed for. And that's really the limit of clinical information that we have. So they may have had at the same time mental health conditions, or they may have developed secondary mental health conditions. We're not sure. In some other research we've conducted, we've found that in this kind of sample, about 9.7% of workers access a mental health service. So, that could be for secondary mental health conditions or mental health comorbidities. We're not sure. Like I said, the only clinical information we receive is that TOOCS information, which is good. We know what they claimed for, but we don't know what they went on to get. And as we know, low back pain, realistically, the pathology has not got a long pathoanatomical life, I suppose, and pain conditions can be quite complex. So I would imagine a lot of these included workers have comorbidities. We just can't tell what they are.
Okay, thanks. Can I ask one more question?
Yeah, go for it.
Does your data have any information on migration status?
No, we don't have
the
that.
Ability to source funding or payments through like private health?
No, so this is only services. I should clarify. Only services funded by workers' compensation. So really, there's we think of 4 options for funding healthcare: out of pocket, private health insurance, Medicare, or PBS in the case of medicines, and then workers' compensation or CTP, so personal injury schemes. But we're only looking at this little bit here. We have done some other research where we were able to use data linkage to link injured workers with the MBS and PBS and other data sources, and we could look at, was their GP service funded by the MBS or was it funded by workers' compensation? But data linkage is quite a complex process, and that project took quite a while. One of our PhD students is currently working on a study of that. But it can be done, but it's quite a challenging linkage process. That would be my answer.
That's a good. We'll watch the space for it then.
Terrific, thank you. Well, we might leave it there. Thank you, everybody, for coming this afternoon. Like I said, if you would like to present at a future session of the Data Interest Group, please do get in touch. Or if you would like any of the papers that you've seen today, they're all currently published. Some of them are open access. I'm not sure, Jonas, but if you would like the full copy of the paper, just send us an email and we can send it your way. Terrific, right? Thanks, everyone.